Abnormal uterine bleeding is vaginal bleeding typically from the uterus that is a variation from normal menstruation, which may be due to abnormal frequency, the menstrual period lasting excessively long, being heavier than normal, or being irregular. Some normal features of menstrual periods are a frequency of 24 to 38 days, bleeding lasting 8 days or less than 80 milliliters of blood loss, and a variation between cycles of less than 4 days. Also remember that bleeding beyond 6 months after the menopause is considered abnormal and may indicate endometrial cancer. Around 30% of women of reproductive age are affected by abnormal uterine bleeding. There are a range of different causes which can be remembered with the mnemonic PALM COEIN. P stands for polyps, which can include endometrial and endocervical polyps that then may bleed. Around 15% of women have endometrial polyps, but most of these are asymptomatic. A is for adenomyosis, which is where there is endometrial tissue within the myometrium, which is the muscular outer layer of the uterus. This tends to lead to prolonged, heavier periods. Next, we have L for leiomyomata, which is the proper term for uterine fibroids. These are benign tumours of smooth muscle tissue and are extremely common, with around 80% of females at age 50 having them. Most of them are asymptomatic. However, the most common symptom when they are symptomatic is heavy menstrual bleeding. We then have M, which is to remember malignancy. Intermenstrual bleeding can be caused by cervical cancer, while endometrial cancer and atypical hyperplasia can also present as abnormal uterine bleeding. Risk factors generally include unopposed estrogen, early menarche, nulliparity, failure to ovulate, and tamoxifen therapy. The C is for coagulopathy, meaning that bleeding tends to be more severe in patients with clotting disturbances. An example would be von Willebrand's disease. Ovulatory dysfunction comes next, and this ties into the ovarian and uterine cycles. There is usually a cyclical production of progesterone coming from the corpus luteum, which is formed following ovulation in each cycle. Polycystic ovary syndrome, anorexia, excessive exercise, and hyperprolactinemia may be underlying causes. E is then for endometrial dysfunction, which is essentially a diagnosis of exclusion, where no structural causes can be identified. I for iatrogenic, which can arise from the use of medications such as anticoagulants or inconsistent use of hormonal contraception. The last category is not otherwise classified, which includes outliers such as arteriovenous malformation and endometritis. The history will help narrow down this wide range of causes and should also include details on the frequency, duration, volume and regularity of the menses. The volume may be hard to quantify and therefore may be expressed as having to change pads or tampons at a high frequency, such as every hour. Symptoms such as increased urinary frequency or urgency, constipation, or low back pain may indicate fibroids. The presence of hirsutism may point towards a diagnosis of polycystic ovary syndrome, while galactorrhea may point in the direction of hyperprolactinemia. If there has been heavy menstrual bleeding since the onset of menarche, then coagulopathy is strongly considered. Laboratory investigations would include a full blood count, as well as a pregnancy test, and further testing can include coagulation screening, prolactin levels, and hormone levels, such as luteinizing hormone and follicle-stimulating hormone, especially when suspecting polycystic ovary syndrome. Imaging is primarily used to look for structural causes such as fibroids, malignancy, or polyps, with ultrasound being one of the first modalities used. It could be transvaginal or transabdominal, with transvaginal being able to better evaluate the pelvic organs. Another option is MRI. An endometrial biopsy is recommended by the NICE guidelines if the woman is above 45 years of age and in younger patients with unopposed estrogen exposure, persistent intermenstrual bleeding, heavy bleeding, obesity, or have polycystic ovarian syndrome or taking tamoxifen. Hysteroscopy is a version of endoscopy used to view the uterus and may be used as first line in some instances, such as fibroids or polyps being highly suspected. As with most other forms of bleeding, there is a risk of hypovolemia and ultimately shock if the bleeding is severe enough. However, in most instances, abnormal uterine bleeding generates a chronic picture of blood loss that may lead to iron deficiency anemia, eventually reaching a point where a small bleed leads to disproportional symptoms. In the case of a severe bleed, pressure is applied to stop the bleed, and in some cases, this is done using a Foley catheter. Fluid resuscitation is given, and often tranexamic acid, which is an anti-fibrinolytic agent, is given. Cross-matching and transfusion may also be needed, and exploratory surgery is also an option to control the bleed in severe cases. In more chronic cases, defined as abnormal uterine bleeding beyond 6 months, treatment may involve hormonal therapy, such as the birth control pill or gonadotropin-releasing hormone agonists. Tranexamic acid again may be used, as well as non-steroidal anti-inflammatory drugs and iron supplementation if the patient is iron deficient. Surgery is also possible, including hysterectomy, endometrial ablation, or the removal of polyps.